I have been involved in writing the IBS guidelines. We first produced BDA IBS guidelines in 2012 and we updated them last year. Were you aware of the original 2012 guidelines? Have you sort of been familiar with them? Yeah? Lots of nods. So the reason that we updated them was because obviously there was a lot more research in the sort of recent years, but also there was sort of failings in our assessment process that we went to in terms of the 2012 guidelines, and hopefully I'm now going to explain to you why we chose the new methods to assess the literature, and that now we have a far more robust set of guidelines for IBS management. Obviously, as time goes on, there's more and more research to look at, so we do have to update them regularly, and we will be updating them again in the future. So for the 2016 guidelines, we produced 2 papers. The first one at the top is the main paper, and that includes all the guidelines that we've set out. And then the second paper is a supplement to that, in that it assesses all the probiotic papers. And what we did for the probiotic assessment was we did a systematic review of all the systematic reviews that had been done on probiotics. So it was an additionally very large piece of work, so it needed to be written up as a separate paper. So the limitations of the 2012 BDA guidelines were that first line advice had not been critically appraised, and very specific aspects for the dietary management of IBS may not have been addressed. So we also only assessed probiotics that were available in the UK at the time, but of course if you want to find a probiotic, you can go online and you can search online and find something if you're specifically desperate to find that probiotic. So we've now extended that out so that it includes all probiotic studies. Also, as I mentioned earlier, the literature searches were old, so they were up to 2010, and we've now updated that to 2016. As I mentioned, we used a far more robust methodology, and we used the BDA and PEN guidelines for critical appraisal and recommendations. We also used a risk of bias assessment tool, and I'm going to just briefly explain to you what that involved. And we developed evidence statements by using something called the evidence statement matrix, which was developed by the NHMRC guidance, and this is an Australian group. We did the comprehensive literature searches up until October 2015, so we're already in 2017, so effectively they're almost 18 months out of date already, so you can see how quickly this moves on all the time. So the questions that we were addressing for the updated guidelines were healthy eating and lifestyle, which included 6 different areas: alcohol, caffeine, spicy food, fat, fluid and dietary habits. We also looked at restricting milk and milk products, dietary fibre modification, fermentable carbohydrates including FODMAPs, gluten, probiotic products and elimination diets. Now, some of these had been included in the 2012 guidelines and some were new to this one. In terms of risk of bias assessment, so once we'd done the literature searches and we'd identified all the literature that needed to be reviewed, we did a risk of bias assessment on each study that was in the papers. So depending on what sort of study it was, so whether it was a cohort study, a case control study or a randomized controlled trial, we would use the correct tool to assess the risk of that particular study. So what we did was we got 2 independent researchers to look at the risk assessment, and they would come together and agree how they would interpret that risk bias. And as you can see, if you look at the question on gluten, you can see there are lots of green squares, less red, and a few yellow. So the green shows that there was a low risk of bias, and each of the different squares relates to a different type of question within that paper. So it might be looking at if it was an RCT, were subjects randomly selected, what kind of randomization method did they use, and so on and so forth. And you can look into the papers and see the information related to that. So the green means that there was low bias, the yellow means that there was unclear bias, so it was difficult to interpret, and the red is where there was high bias. So this gives you a really clear indication about the quality of the papers that we were actually assessing. And if you look in the guideline, you can see the colour table demonstrating this, which is very useful so that you can see how what the risk of bias was for each of the studies included in the guideline. So we developed evidence statements for each question, which would then lead on to an which would then lead on to a recommendation. And for the evidence statements, we used a matrix which would look at the evidence base and the consistency of the literature that we were assessing, the clinical impact, the generalizability of it, and the applicability of it. So for each question that we had, we may have had 4 papers, we may have had 7 papers, and we were trying to understand what all of those meant in each of these different categories. And then from there, we would draw up an evidence statement, and that would then lead us towards the recommendations and the grade of recommendations. So depending on the quality of the studies, we would be able to then see what the grade would be. And I'll come on to that in a moment. Any unresolved issues that we felt were had not been addressed, we could then record down, and that might come into the discussion points of the guideline. The implementation of the recommendation, there are various components that you want to consider at this point. So would that mean that there's be a change in care? Would there be any resource implications? Changes to organisation of care, and barriers to change as well. So depending on what that recommendation was, we would then put that into the practical aspects and the discussion points within the guideline. So in terms of the PEN evidence grading recommendations, level A suggests that there's good evidence, level B, fair evidence, level C, limited evidence or expert opinion, and level D, evidence is limited. Now we have, as a separate sheet, I think you've got somewhere the recommendations of the BDA guidelines. They might be in your pack actually, so they might be halfway through the pack. Well, they're separate. I think they might be halfway through. Don't worry, we'll come to it later anyway, during the day. So we came up with an algorithm. In 2012, we had an algorithm and we updated this algorithm. And if we just run through this briefly, first of all, you have your IBS diagnosis. And in first line management, when you see that patient, you want to check that that diagnosis is the correct diagnosis. So look at the clinical investigations that have been carried out. Make sure that you've ruled out celiac disease because there's a big overlap there. So if you get referred anybody who's got a potential diagnosis of IBS, you need to make sure that that celiac disease diagnosis has been ruled out. And then you would take a detailed history from that patient and try and identify what their symptoms are. And gradually through this morning, hopefully you'll be touching on all of these different areas so that you'll start to get some understanding about why we do all of these different things. For first line dietary advice, we're going to be covering that again this morning. But to be able to do the assessment, you need to assess dietary habits and check healthy eating and lifestyle, and also assess if there's any food intolerance issues, particularly related to milk, and then assess dietary intake of things like fat, alcohol, caffeine, spicy foods, fibre, and eating habits as well. We also look at probiotics within this section as well, within the first line. And then if you find that the patient that you're seeing has not improved in terms of their symptoms by using first line advice, you would then consider second line advice. Alternatively, you might go straight to second line advice if the patient is already following a healthy diet and there doesn't appear to be any issues with the first line aspects. So it's really important that you as the dietitian are making that decision as to whether that patient needs first line advice or goes straight on to second line advice. And you may find that second line advice is the most appropriate with a few minor aspects of first line advice. So you might actually think that the patient needs to have second line advice in terms of the low FODMAP diet, but you might also think that they need some adjustments to their dietary fibre intake, their caffeine intake as well. So you might do it all together as one appointment, one session. Hopefully by the end of today you'll have understood what all these different aspects are and you'll feel more competent going away, that you're going to be able to make sure that the patients are being advised appropriately. So the key messages here are that first line advice is based on healthy eating and second line advice is based on the low FODMAP diet. There were a few areas where we found there wasn't adequate high quality evidence to be able to bring them into the guideline. So for example, gluten is a big area of controversy, and at this time we can't make a recommendation that people should be following a gluten-free diet to treat IBS symptoms. Elimination diets, we had a third line in the 2012 guideline. However, the elimination diets were really something that we had used historically and were never particularly helpful at identifying dietary triggers, and we decided that because of the effectiveness of the low FODMAP diet, we stopped using elimination diets. So we've taken out that third line aspect. For probiotics, we'll touch on this a lot more as the day goes on, but just to give you an idea, we had 9 systematic reviews and 35 of the RCTs within those 9 systematic reviews were included because they met the inclusion criteria. And it involved 3,406 patients. And from all of this evidence, we came up with a recommendation that to advise that probiotics are unlikely to have substantial benefit to IBS symptoms. However, individuals choosing to try probiotics are advised to select one product at a time and monitor the effects. They should try it for a minimum of 4 weeks at the dose recommended by the manufacturer. And we also identified that taking a probiotic is safe in IBS. So if they want to take them, there's no problem in terms of their safety, but it may be a cost that they don't want to be introducing. So that's recapped sort of where we are with moving forward with the IBS dietary guidelines. And these are approved by the BDA. It was the gastroenterology specialist group who produced the guidelines. So do know these inside out and back to front if you can. So just to conclude, all aspects of the diet were critically appraised. We used a much more robust methodology. There's now first line and second line advice. Gluten, inconclusive evidence. Elimination diets have been removed. And probiotics, I think it's an area of development still, and it will always be of interest to the public.